Good day, friends, and a warm welcome to this edition of 4D. It's season 3.0 going on, and 4D means detailed discussion and dialogue in diabetes, in Indian diabetes. Many of us will say, what is the need for so much detailed discussion and dialogue? The reason is that diabetes itself is a dynamic disease, and if we wish to defeat diabetes, we have to be more dynamic, even more dynamic, one step ahead of diabetes. And the more we talk to each other, the more duologue, the more dialogue we have, the stronger we become. If we wish to be dynamic, then we need dynamic experts, isn't it? So let's welcome our experts today. First of all, a warm welcome to Dr. Ritika Bansal. Madam is a nephrologist at Crystal Healthcare in Bathinda, Punjab. Welcome, madam.
Thank you, sir.
Ma'am, there's this question coming in, and it's from all over the country. They say that we know what Punjab is all about, but what is Bathinda famous for?
I think currently it's famous for AIMS Bathinda.
Okay, that's
And
nice.
and it was used to be famous for the thermal plant it used to have. Then we have the national refinery here. So that is what Bathinda is famous for in India.
So a lot of industrial projects and an upcoming AIMS, which has actually become one of the most successful all India institutes in the country. Thank you, ma'am, for being with us. Let's also welcome an equally dynamic young endocrinologist, Dr. Javed Ahmed Sofi. Warm welcome, Dr. Javed.
Thank you, sir. Thank you very much, sir. Good evening, everyone.
Dr. Javed works at Government Medical College, Baramulla. And so, Dr. Javed, a question for you. What is Baramulla famous for?
Sir, Baramulla is famous about the Gulmarg. Gulmarg, it is beauty. And it's also famous about the rivers and other so many things here in Baramulla. And most important is the snow. Everywhere in Kashmir.
So natural beauty. And Dr. Javed, just a question. Bathinda is also beautiful. There's a lot of greenery. When you go to Bathinda, depending upon the season, either you will see everything green or you will see everything golden. Depends upon which crop is growing and how it is like. So what color is Baramulla? In winter, we agree it's snow. It would be snow white. But what are the other colors?
It is definitely white. In the autumn, it is yellow because there are chinar trees are here, and during the summer, it is green. Everywhere it is green, and more important, the temperature it is almost about 30. It doesn't cross beyond 30, 32. Basically, if it crosses, then there is definitely a rainfall. So if we at this time still temperature is we can manage it without this. You can understand at this time even without AC we are managing the temperature. That's very difficult in Bathinda to manage it without AC this time. So it is cool and pleasant here.
It's very hot and humid here at present.
But then this is nice, Dr. Ritika. See, look at the beauty of our country and also look at the beauty of diabetes as a syndrome. All different colors. So the same way, Dr. Javed or you say that depending upon the month of the year that you come to visit us, we'll have a different temperature, a different weather and different color as well. Do you feel that this is true for people living with diabetes? And
definitely, sir.
The colors change.
Yes, sir. Yes, sir. Basically, during winter months, if we see people they are physically inactive, mostly they are indoors. They wear their congles or other things. They are not that much active, and diabetes definitely blood sugars go high, HbA1c go high, uncontrolled sugars are there. And one more important point I want to convey here that mostly in winter season in Kashmir, the stroke risk is more as compared to during the summer season of stroke. It has stated that during winter, hypertension is also high on the cards during the winter season. And of course, diabetes because inactivity, sitting at the using those congregates, other things. No outside people are just they are sitting at the home and blood sugars, hypertension and controlled hypertension. They're very common during that time.
So what Dr. Javed is saying, let's take this part in extreme winter, you will have more of hyperglycemia because there is physical inactivity. I think this is true for most of the plains as well in North India. You will also have greater risk of stroke. And he mentioned about Kangri. So Dr. Javed, people listening to you from across the country, what does Kangri mean? And could you talk about Kangri with respect to neuropathy and with respect to...
Kangri is a type of one that mod it where there is a we keep that fire inside it and it is used for water. Kangri. This is very important regarding diabetes. Mostly they have neuropathy, DSP, and they usually have primary burners, they have diabetic foot ulcer, and they have blisters, other things. It percepted more during winter season because of this kind. Although it keeps the warm, I am myself using it. But the issue with that for diabetes, because they have already neuropathy and they use it, they develop these blisters and then diabetic foot ulcer and osteomites, so many complications with this point. And one more state was here from Kashmir that they have a gangrenous cancer, squamous carcinoma, burners, leads to long duration can lead to squamous carcinoma.
You can have Kangri burns and Kangri cancers as well. And maybe people would have known about this in the past, but because diabetes is increasing so fast, and then autonomic neuropathy is also coming in, sensory neuropathy is coming in, it is possible that we are missing out on many patients. There's another challenge with this, Dr. Javed. Do you see this? That let's say I developed a Kangri burn. My first contact will be my brother, my brother-in-law, my friend, my neighbor. I'll go to him and say I developed a Kangri burn. He'll say I also developed one. So it's normal. No need to go to the doctor. Do you face that kind of a problem and people not coming to you for things?
Definitely, sir. During rural areas, because of health sector, that is very, and during winter season, that vehicles are very difficult to get vehicles. At that time, these are managed by some we say that peers and other things. They manage these things, and later on they develop this complication. Usually, they don't give antibiotics or they don't advise the patient to go to the doctor or something like that. They do that, that we call it that desi ilaj, we call it that. And because of that thing, definitely they develop complications, uncommon sugars, and then diabetic foot ulcers, and so many things. And finally, amputations are common during the winter season. This is the problem here, sir, especially in rural areas. Not in urban areas, because in urban areas, one is noise less, mobility is more, and easy accessibility to the scheme. In Srinagar, so many institutes, Scheme Medical College, so many institutes are there. There is an easy accessibility during the winter, but problem difficulty is with the rural area. And they have a difficulty in attending the health sector immediately.
Dr. Ritika, thank you. So many different colors. First of all, Dr. Javed was speaking about different seasons, but even when he focused on winter, even there, look at the colors. Neuropathy leading to burns, a different type of microvascular complication. Stroke, a different type of macrovascular complication. And the key cause is hyperglycemia. One of the other microvascular complications that is so frequent is nephropathy. So what about the colors that you see, Dr. Ritika, as a nephrologist? It's summer and winter both.
Yeah. Sir has very diligently discussed about the problems he faces in the winters. At present, the problems which I am facing as a nephrologist in this hot and humid weather, one is dehydration, patients coming with hypotension, those who are on ARBs and multiple medications for the control of nephropathy or any other illness it may be. Then second is the urinary tract infections, which definitely increases in summers because of sweating, increased risk of fungal infections, and we have to be very cautious in the patients who are already on SGLT2 inhibitors. And many patients, they actually land up with symptomatic postural symptoms, and we have to cut down on their antihypertensives and optimize their other treatment in this hot and humid weather. Then risk of acute kidney injury, sir. In this hot, humid weather, people are going to long trips, then they have rhabdomyolysis and tropical illnesses. That also leads to acute kidney injury in the patients who are already having nephropathy or renal dysfunction, and their kidneys and cardiac both get compromised when they have any acute insult. And last but not the least, I would like to mention, as sir was already discussing about the Kangri ulcers, when I was working in Udaipur, there is a practice called as Dam practice. For pain relief, they use this hot coal or a hot metal object for the patient to have pain relief, and the patients used to come with this big ulcers over the skin. And this was an interesting thing which I encountered there. And especially these diabetics and all, they will develop skin and subcutaneous infections second to that. So this is the color which we see in the summers. And winters, it's almost the same. Increased blood pressure, poor control of BP, we'll have to increase the medications, and worsening of glycemic control, which I also see in summers. Patients, they're very fond of mangoes and lychee, I think this you must also be encountering. So, and another my fear is hyperkalemia secondary to these fruit intakes. And in this hot weather, increase intake of coconut water, lemon juice. So patients do come with hyperkalemia, especially those who are on ARBs and ARNI or Finrinon. So we have to repeatedly counsel the patients and just look at every time what they are actually eating. Those who don't have hyperkalemia in the past and now coming up with severe hyperkalemia. This is what I'm seeing here, sir.
So again, look at the different colors. See how Madam has explained. You have pre-renal diseases or causes of AKI like dehydration. Then the renal causes and the post-renal ones also like UTI. And all these you see. And then you see the different colors, whether it is Baramulla or it is Udaipur. The same pathophysiology, the same process, just the words have changed. There are so many things to talk about, but Dr. Ritika, you mentioned about we have to change the antihypertensive medication. So let's ask Dr. Javed first and then you. If I read the textbook, if I read Harrison's textbook of medicine, or I read maybe Brenner, which is nephrology, nobody tells me, none of the books tell me that I have to decide my blood pressure dosage, anti-blood pressure dosage, based upon the month of the year. Does this actually happen, Dr. Javed, in Kashmir, that you have to change the dose of antihypertensives in summer and winter? Let's take your answer and then we go to Dr. Ritika. For the time being, we focus only on antihypertensives, not on other drugs.
Definitely, sir. Basically, what we are trying during winters, cold outside, vasoconstriction, hypertension, focus cancer, high ambulatory, non-ambulatory blood, this weight gain is there. Definitely, sir, there was a study from the Kashmir. They have seen that when winter season, blood pressure mean every was higher as compared to during the summer. Cancer is ICH, more as compared to. Definitely, there is an increase in the. We need to increase the dose of these antihypertensives. We need ask the patient to keep a continuous follow-up of this health sector and keep an eye on the blood pressure. And definitely, if a patient is diabetic, we have to make him aware that by little bit increasing the physical activity, even by some yards at home, there can be a control of blood sugars. And day by day, there is increasing this DM endocrine in Baramulla, in periphery degree in districts. Every DM endocrinology, there is a visibility that patient can visit to near DM endocrinology or nephrologist.
So we do need to change, and it's a good idea to
that
do a
availability
patient
there. And definitely.
So Dr. Javed has mentioned actually clearly that yes, there is a seasonal variation in our choice of treatment as well, which is not mentioned in the Western books. Yeah. Dr. Ritika, would you like to take this further? So we know that we need change according to seasons, and Bathinda is blessed with extreme of all seasons. There is nothing that is not extreme in Bathinda. So let's focus, ma'am, on diuretics perhaps, and then ACE inhibitors and ARBs. What kind of changes are you making now in your clinic? What kind of your changes will you make in November or December?
So at present, I need to cut down on the dosage of diuretics and reassess whether the patient actually needs diuretic, because it's so hot and humid. Third space loss is pretty high. So it's every visit I do assess whether I can cut down on the diuretic for the patient. That is very important for the patient because that can again precipitate pre-renal acute kidney injury in the patients. And coming on to the other category of diuretics, one is the loop, other is the thiazides. Thiazides are notorious to cause dyselectrolytemias, which is very common in cases of hot and humid weather, where the salt and fluid loss is occurring through sweating. Because in Bathinda, majority of the population is farmer population. They are actually working out in the fields in this hot and humid weather. And otherwise, it can precipitate hyperuricemia and gout in the patients in such a weather, because uric acid will get crystallized and precipitated because of the dehydration part. Coming on to the winter season, definitely yes, there is increase in the BP mean BP increases during the winter season, and we have to optimize the dosage of the drugs. Many patients, they do have their recurrence of heart failure symptoms and edema in the winter seasons. So we have to again reassess whether we should now start them on the low dose of diuretics and optimize their antihypertensive medications.
You mentioned about edema, and that is important. We see it very frequently, and we'll talk about heart failure later. But Dr. Javed, so often in the OPD we have patients with edema. We do all the testing, we are not able to find out the reason, so we then assume it may be idiopathic or iatrogenic. Let me take the iatrogenic part first. Iatrogenic means there is some medicine that we are giving which is causing edema. A medicine alone may not cause edema, but if you give two of them together, that can cause edema. Let's take one example from endocrinology, from general medicine. That is when you are giving DPP4 inhibitor and ACE inhibitor. ACE inhibitor alone will never cause edema. Ramipril and enalapril will not cause. Sitagliptin, vildagliptin alone will also not cause edema. But when you give both, you are inhibiting two enzymes, DPP4 and ACE. These two enzymes are used by the body to break down bradykinin and substance P. If I inhibit DPP4 and ACE together, there is nothing left to break down substance P, and that can cause edema. Now, the issue with diagnosing iatrogenic edema is that you have to read the pharmacology, and all of us have different levels of memory. I did my MD pharmacology now 35 years ago, my MBBS pharmacology 35 years ago. So I've developed something, Dr. Ritika, called memory porosis. So just like Dr. Javed, we have osteoporosis. So all of us have different ideas of what iatrogenic means, but we should be aware that some drug combinations can cause this. Also, we should be aware that drugs which we think are so simple, maybe pregabalin, that will also cause a little bit of edema. Amlodipine will cause, cilnidipine will also cause. So apart from all this, Dr. Ritika, if I were to ask a specific question, salt intake and protein intake, do you see in your OPD that excess salt and insufficient protein is a cause of so-called idiopathic edema?
I do encounter such patients, sir. They come to me for edema, and when we ask about their diet and we calculate, because it's a common myth in the society that if you have a renal disease, just cut down on all the sources of protein, which is actually not true. We all know, sir. We have to take a moderate to normal amount of protein, even for chronic kidney disease patients. So I do encounter this hypoalbuminemia is a very notorious cause for edema in the population, because it is due to malnutrition only, sir. You don't find any significant proteinuria in these patients, and there is no evidence of heart failure. Once you correct their malnutrition part, their edema definitely goes. And second, salt intake. When I personally advise patients to cut down on their salt and ask them to follow up after just 2 weeks, many patients happily come that bina dawai ke hi we don't have edema now. Yes, sir, I do encounter these patients, and most notorious is NSAIDs. All the NSAIDs are an important cause of edema in our population. Patients are taking NSAIDs, and when you just check their medications and just cut it out, edema will definitely resolve.
Dr. Javed, your comments. Salt intake in local cuisine, Kashmiri food is very tasty. Can you make tasty food without salt? So salt and protein and edema, how does this play out in your OPD, and what advice do you give your patient? While we wait for Dr. Javed to respond, in my OPD, initially this was one of the toughest things, Dr. Ritika, when I started practice. Dr. Javed is with us. Okay. So I would tell my patients stop ghee. They would listen. Whether they stopped or not is a separate matter. I would tell them cut down on free sugars, that and halwai wali mithai, that also they would listen. Whether they follow or not is a separate thing. But the moment I would say cut down on salt, I would find that suddenly the patient, if she's a lady, or the patient's wife, if he's they would look at me as if I've committed the biggest crime on earth. It took me so long to understand why this is happening. Then when I kept on seeing why is it that people become so angry or they look at me with hatred when I'm telling them to stop salt, I realized this was limited to just one or two ethnic groups. All the ladies were not doing that. It was one or two of the more conservative ethnic groups where this anger or hatred was coming. Then I realized that particular lady, she knows only one way of keeping her husband and her family happy. That is cooking. And that is what she has been trained in. And now suddenly I have told her, you stop salt, you stop sugar, and you stop saturated fat, which is ghee. What else is left in diet? And she feels that I am going to make her, redundant in her family. That is why the hatred was there. I changed my counseling style, and I began saying, of course, we must reduce salt. Why don't you view it like a rosa or like a vrat? Let's do it for a couple of days and see how things are. That's one thing. And I would give an alternative. So all the other spices. So whether you're speaking in English or in Hindi, and we have people from across the country, so you can say hing, lasan, pyaz, mirch, red pepper, green pepper, blue pepper, whatever. And why don't you use these spices in the OPD? And now all those ladies, now they are quite happy with me. We've all become good friends and they follow the advice. Have you faced any challenge like this, Dr. Ritika, in your OPD?
Yes, sir. Punjab hai. It's an agricultural belt. All have dairy cattle at their homes. So lassi and curd is favorite of people. And lassi bina namak, kala namak, they're not happy and they don't accept it. So again, my advice is almost the same, which you already said. I tell them, jeera bhoon ke, you add it, hing and mirchi ka tadka lagao, and then people are happy. Now they say ki it's good. And sometimes I advise them to use mint leaf, fresh mint leaves also, to just add on to the flavor. So people are now actually accepting it and they are reducing down on their salt intakes.
Mint and basil are my favorites in Hindi, pudina and tulsi. So we tell
Tulsi
them
and pudina.
that when you are sort of preparing your curd at night, when you are letting the milk out to set, you put 2 leaves of mint, that is pudina, or 2 levels of basil, that is tulsi, whatever you like, and that curd or that lassi you can take in the morning. And usually people will complain, I don't mind taking curd, but I get knee pain with that. That is such a common thing. So we tell them the tulsi and the pudina will fight the knee pain.
That will take care of it.
Now, whether it is a placebo or not, I honestly do not know. But we call it a socibo, social placebo. And that's how things work. Dr. Javed is with us. Dr. Javed, always you should have a plan B in practice. So supposing your patient says, so you tell your patient, why don't you take pudina? Patient says, I hate pudina. Then the plan B is tulsi. So this I saw in my practice. Let's ask Dr. Javed how he feels. So we'll tell our patient, "Aap doodh lein, you take milk. Now, milk is not tasty. I don't like it, or I get bloating." You tell them, okay, why don't you take curd or lassi? That also they find an excuse, knee pain. Yes, so then we tell them, if you're not well, and this is our go-to treatment for chilblains here. So then we tell them, why don't you take tea or milk with saffron? Now look at the feeling, and Dr. Ritika will smile from an all India point of view. If you say, why don't you take kesar wala doodh, that is saffron milk, that gives you a feeling. But the moment you say zafrani chai, zafrani doodh, which is in Kashmiri or Urdu, that gives a totally different romantic kind of a feeling. So I have seen in my patients, when I say kesar wala doodh, it doesn't work, but the moment I say zafrani doodh, that works. So Dr. Javed, and how you use that at home.
Sir, basically this saffron issue with this, which is very costly. Although only 10 to 20% population can use it, is very costly. 1 gram costs more than 1,000. But the kahwa by this zafrani is very famous here, especially in Pampur. So if we use that, people believe that this is used for so many. It is used for so many diseases. They have a myth in the mind that it can cure even diabetes, even hypertension, even thyroid diseases. This zafrani kahwa. So this, especially this Pampur is very famous for this. Yes, majority people use it, especially those who have a accessibility of a good amount of pocket money in their pocket. But the issue with this is that especially the people who come outside, they are very famous for this. You know that this is like zafrani. They are searching this zafrani in Pampur and other districts. Majority people, they can use it, but they have a belief that it can cure so many, especially hypertension, thyroid, and even diabetes also. There's a myth here. And especially they use that this kahwa is used along with the sugar is added in this. But still they believe that it can control our diabetes, our hypertension, and our thyroid. They have a belief this thing.
That's nice, Dr. Ritika. हर एक friend जरूरी होता है. And so thank you, Dr. Javed, for teaching us something nice. Now we have plan C as well. In case our patients don't respond, we'll tell them to keep on taking our medication, but we'll add kava. But Dr. Javed, if we want to talk about kava to our patients, we are speaking from an all India perspective. Is there anything we need to know? How much kava should we recommend in summer and winter? And what are the caveats? Are there any contraindications to using kava?
There are no correct, but mostly people here in Kashmir, they use in the winter season. Winter is mostly used for this because we add sugar along with this. And number second thing is that during winter we have a cough, upper respiratory symptoms. It is also our elders, they used to say that cure this upper respiratory symptoms, infection, pneumonia, other things. So even in my home we use this kava. Even Zafrani kava we use, especially during winter season. But I have my mother, please don't add sugar in this. Also diabetic.
That's the
advising her to don't use sugar in this. Yes, sir.
Also,
mostly
thank
we
you.
use it.
This is people listening from all over the country, and Dr. Ashish Sehgal, who's an endocrinologist trained at SKIMS, Srinagar, where you also trained, he's saying thank you to you.
Sir.
He says, I've learned something new. I will now use it as an immunomodulator in people with, frailty, maybe metabolic frailty, and I will also use it in winter as a vasodilator to prevent or to manage chilblains. And many of our patients with neuropathy, in winter they complain more of numbness, so we can use it there. We just have to remind them not to add sugar.
Yes, sir.
Dr. Saqib is with us. Warm welcome, Dr. Saqib. As we wait for him, our topic was heart failure. So see, so many things we are discussing. We are talking about how to speak with our patients, how to listen to them, plan A, plan B, plan C. Of course, the medicines must be given. When a diuretic is indicated, you must write. When an antihypertensive is indicated, we must write. But many things are there which are not written in the book. For example, causes of edema, salt intake. The person who wrote the book does not know how food is prepared in Batinda or Baramulla. Seasons. The person who wrote the book sitting in USA or in UK, they are not aware of how much change can occur in our temperatures in just 2 months. One is inside the home and outside the home. Second is even within the home, whether you're using a kangdi or not. So all these things put together, heart failure is a common condition. So let's take Dr. Ritika first, then Dr. Javed. Dr. Ritika, is heart failure common in nephrology? How would you differentiate between fluid overload and heart failure?
It is definitely common in patients who have renal dysfunction, and those patients who have diabetes, they are at more risk of developing heart failure, even with preserved ejection fraction. Forget about the reduced ejection fraction, which is the commonest cause of having heart failure. And in patients with kidney disease, there is another etiology, which is pulmonary edema, which may not be secondary to the heart failure. So coming on to this differentiation, sir. So one more important thing, fluid overload usually develops in the patients who have advanced renal dysfunction. When the GFR declines to less than, say, 25 to 30, then only there is risk of patient going into fluid overload or pulmonary edema, secondary to the renal dysfunction. And in patients who have massive proteinuria, for example, we come across the nephrotic syndrome patients, they'll have full-blown NSARCA, then only they will land up in pulmonary edema. So one more important thing in these patients is just inquire about their symptoms. We just have to follow the chronology of the symptoms, that whether the dyspnea came first or the edema came first. Usually if the patients have heart failure, then they will have dyspnea coming first, then leading on to the development of pedal edema. Whereas the opposite happens in cases of patients who have nephropathy or massive proteinuria or nephrotic syndrome. Even diabetic nephropathy can present like a nephrotic syndrome in fewer cases, not a common thing, but definitely it can occur. And next important thing is the edema, distribution of the fluid, and degree of renal dysfunction. If renal dysfunction is quite high, say the GFR is less than 25, patient has edema and patient has dyspnea, then likely my probable clinical diagnosis will be fluid overload in that patient. And you can get the supportive investigations the most important will be getting an ECG and echocardiogram done in these patients and look for the ejection fraction, LV diastolic dysfunction, which if there is no diastolic or systolic dysfunction, then likely it's going to be fluid overload. Even if there is diastolic dysfunction, heart failure still will be there. And mind it's a very common thing that we can have overlap of both the things in our patients. That they are having underlying heart failure, along with that the patients have renal dysfunction.
Ma'am, one question. This is asked by Dr. Khyati, who says I am doing my internship in Kolhapur. She says, ma'am, I have been working in emergency now in medicine, and my question is, isn't the treatment the same whether the patient has fluid overload or heart failure? Ma'am, is there a reason? Is there any importance that we find out the difference to do the differential diagnosis? How will that impact us in the long term?
The long term impact is going to be in the choice of the drugs which you are going to offer to the patient. Although the first line management is to decongest the patient, that is going to be with the help of loop diuretics. But in the follow up and for the future benefit, so the drugs again, it is a cardio-renal metabolic overlap thing. So the drugs are also going to be almost the same. But if the patient has a primary cardiac component, then I would like to choose ARNI for those patients. I would like to choose beta blockers as a first line therapy, which we may or may not choose for the patients who have fluid overload secondary to kidney disease. So that becomes important. And other thing is the benefit of SGLT2 inhibitor is going to be same for both the category of the patients, but we won't be able to offer these drugs if the patient has an advanced kidney failure, because these drugs also come with their own side effects. Like SGLT2 inhibitors, we don't offer to the patients who have a GFR of less than 20 or 25. Same goes for Finbrinon, same goes for ARNI. But that is important why you need to distinguish between the two. And last but not the least is the mortality benefit which you are going to offer to the patient based on the treatment. If a patient has heart failure, then likely the mortality is going to be higher.
Thank you so much for putting this in perspective. The question was excellent actually, and the answer is yes, immediately you might want to give the same emergency medicine care. But in the long term, how you will counsel, how you will care for your patient, that changes. Of course, it is just one spectrum, cardio, kidney, or cardio-renal metabolic spectrum. They are all different parts. And then how we started different colors of India, different colors of the year, and different of the seasons, and different colors of patients who come to us. This is again being put in perspective. Thank you, Dr. Khyati. Dr. Javed, one other color that is being spoken about more and more, and it's a very heavyweight color, that is obesity. How would obesity impact edema? How would it impact heart failure? How would it impact our choice of therapy? What are the challenges you are facing these days? What are the opportunities that are coming up?
Definitely, sir. Obviously, it is a pandemic now. If we see, our topic was CKM. If you see the basis of this CKM is obesity. There is obesity, there is inflammation, there is hyperglycemia, there is hypertension, coronary artery disease, MSLD, liver disease. Everything is on obesity. So the main thing we have to tackle if we discuss the CKM is that obesity. There is a main. So there occurs the endocrinology perspective. So for this obesity tackling, we have lifestyle modification, which is very difficult in this current scenario to change the lifestyle of the patient, to ask him for physical activity, take less calorie diet, other things. The second option we are using here is that SGLT2 inhibitor. They have a weight loss benefit and they have cardiovascular renal benefit. And the third choice is definitely GLP-1. Here and there we are using. We have SEMA molecule is semaglutide, liraglutide, other things which have cardiovascular benefit. They improve diastolic dysfunction of the heart. They have a CCF benefit, like there was a trial, DAPA HF trial, Empire trial. They have a cardiovascular benefit. SGLT2, semaglutide, we have a cardiovascular benefit. In MSLD, we have semaglutide. There is a MSLD benefit. Renal flow trial was there. It has a renal benefit. So definitely, the obesity is the mother of here. If we tackle the obesity, we tackle the congestive cardiac failure, we will tackle the MASLD, we will tackle the CLD, MASLD, we will tackle the nephropathy and other things. So main thing here, we have to tackle the obesity by lifestyle modification, by drugs, and by so many things which are available in the markets.
Thanks for putting this in perspective, and we suddenly realize the spectrum is becoming larger and larger, more and more diseases. But finally, at the heart of everything lies the heart, isn't it? So, a warm welcome to Dr. Nazmi Saqib. Warm welcome, sir.
Um, Good evening, sir. Thank you, sir. I'm really sorry I was stuck in the case, and my network is quite poor here. I couldn't get you clearly, sir. Can you please repeat your question?
A question coming from all over India. The entire nation wants to know whom does Dr.
Yes,
Saqib's heart beat for?
sir, for my family,
So, very
and
same
definitely for my patients too, sir.
for patients too. But we
Yes,
have
sir.
only one heart and we have to keep on sharing it. So, Dr. Saqib, warm welcome. Dr.
I'm, I-
Saqib
I'm
is, yeah, a cardiologist working at Ujala Cygnus Hospital in Jammu. Dr. Saqib, we were talking about various colors. So, colors of the seasons, colors of patients. What about cardiology? There was a time when I was a student, all cardiology for us used to be only rheumatic heart disease. So, you would
yes, sir.
excuse us if we thought that the heart has only valves. There is nothing else in the heart apart from the four valves. That is how our practice used to be. A differential
Yes,
for us would be pericardial effusion. Then we would know that yes, the heart has pericardial fluid. We
very
never
critical.
talked about heart failure or fluid overload in those days. And
Yes,
coronary
sir.
artery disease, when I was an MD exam going person, one of the spotters in my exam was a person with a CABG scar. It was that rare that they put it as a spotter in the MD. And half of us failed. We had never seen a CABG scar before. So, what is cardiology now about? Is it only about the walls? Is it only about coronary arteries, or is it about different colors, different shades of cardiac disease and health?
I believe, sir, hemodynamics always has been the most important forte of cardiology. And definitely, valves too are very important. Now we have evolved so much when it comes to valves. Earlier, it used to be only the open surgeries, but nowadays, as we know, we are doing TAVRs, we are doing TMVRs. The new focus is altogether on the TMVR. And definitely, coronary artery disease is there. And apart from that, sir, it's not only the cardiac health, it is the cardiorenal health that we are talking about nowadays, sir. As a system, as a unit, sir, we are talking about obesity, we are talking about heart failure nowadays. Earlier, the only entity that was discussed in detail was HFrEF, but now the focus is also on the HFpEF, which is more of a metabolic kind of syndrome. So cardiology is much more and beyond valves, beyond coronary artery disease. So we need to see it as a unit, the whole body as a unit, where the heart, the kidneys, they work in tandem, and we need to take care of both of these organs in a very precise, in a very detailed way, sir.
So, just like all the colors put together, they make a very beautiful rainbow. Similarly,
Rainbow.
if we see all the organ systems of the body together as one rainbow, actually there is more beauty in addressing it and in also managing it. Dr. Saqib, there is this test called NT-proBNP. Dr. Javed हमारे ये कहते हैं. Dr. Javed says that the heart is an endocrine organ. It produces hormones. All the diagnosis is done using hormones, and it says that we outsourced the management of the heart to our fellow colleagues in medicine and in cardiology. So, what is NT-proBNP? How accurate is it, and what are the caveats when we assess this number?
Sir, it's a very important investigation where we can diagnose the heart failure in a patient. The elevated levels of NT-proBNP are always very helpful in diagnosing heart failure, especially when on an echo you see patient is having normal ejection fraction, but you still see there are elevated PA pressures, and then you take the help of this hormone, this NT-proBNP, which is a stress hormone released by the atrium. So helps you diagnose the heart failure very precisely. Especially, I rely on it more on the practice, in a practice where we have difficulty in differentiating between the renal ailment or a cardiac ailment. And at the same time, we should be mindful of certain diseases where we can have falsely elevated NT-proBNP levels, especially in a patients who have got severe sepsis. There we can have the elevation of NT-proBNP also. But overall, it's a very precise test for heart failure, and yes, it helps us a lot in diagnosing heart failure.
Dr. Ritika was speaking about heart failure and the overlap between renal and cardiac disease. So, madam,
Yes, sir.
your comments on NT-proBNP, Dr. Ritika. NT-proBNP from a renal perspective.
So it's a hormone, as rightly sir said, secreted by the atria, and it responds to the stress which the atria is facing. So NT-proBNP, it actually gets cleared, metabolically cleared by the kidneys. So when you have renal dysfunction, another caveat is that in the patients of chronic kidney disease, NT-proBNP levels can itself be elevated. On those patients, we have to cautiously just rely on the NT-proBNP levels to label the patient as heart failure or not. That is from my side, sir. That one another caveat which you were asking in the chronic kidney disease patients, so NT-proBNP levels are high. So, what level do we take? There is no cutoff as such which we can take in patients of chronic kidney disease. In those patients, some experts do say that you can have the serial monitoring of the level and go by the clinical symptoms of the patient than just relying on the value of NT-proBNP.
So the clinical aspect is, yes, Dr. Sakib.
I have a question here, sir. I just would like to ask one thing to all the eminent panelists here. Is it the elevated NT-proBNP in a CKD patient a marker of just a renal thing, or we can say that these patients do have a tendency of having some amount of heart failure also? So how do we differentiate that? Because we are not doing cardiac MRIs in those patients. We are not doing the strain imaging in these patients. So is there some overlap of heart failure in patients who have got CKD or not?
Definitely. Definitely, there is an overlap. As I already said, we cannot just go by the level of NT-proBNP. Go by the clinical significance, and if you are actually sure, or if the index of suspicion is high, then it's better to go for a serial monitoring of the level. If it is increasing trend, then you can say that the patient is having underlying heart failure. And no such cutoff has been defined. Like in the normal patients with normal GFR, you take the cutoff as, I think, 300. There is no cutoff as such defined for the levels of GFR. For all the studies and the literature reviews I searched, there is no particular cutoff. You have to go by the clinical judgment in those cases.
It becomes even tougher if you have a person living with obesity. So in CKD, renal clearance of NT-proBNP or BNP is reduced. That's why the levels become high. But in adipose tissue, our adipose tissue is also an endocrine organ. So for example, it will break down testosterone. It also breaks down BNP. So the receptors for BNP are higher in adipose tissue. That is why levels go down. And in a person living with obesity, the NT-proBNP levels will be lower. So you might miss heart failure. You'll say, yeah, it's only 250, nothing to be done. And if it is obesity and CKD together, then the numbers are very dicey. So I guess repeated checking would be the best way.
Exactly, sir.
Dr. Javed, we were speaking about salt, and then we were speaking about protein also, and kava. So, Dr. Sakib, how do you use kava, or how is kava misused in cardiac practice? This is what we all want to know. Any cardiac illnesses that are precipitated by drinking excess of kava, or perhaps sometimes you wish to use its medicinal properties to help your patients?
So for me, it's only HFrEF thing where I would be very cautious about using any liquid diet for the patients. I mean, I have to restrain them from taking excessive fluids. Apart from that, sir, kava only has got health benefits if your heart is healthy. And I don't see any issues if patient is having a healthy heart. But yes, in patients with HFpEF and HFrEF both, where you don't want to have fluid overload, you would definitely ask patients to refrain from drinking excessive liquids.
And otherwise, we might want to use it. Yeah, Dr. Javed, carry on.
Regarding this salt, sir, we have here the salt tea. Every Kashmiri is using salt tea in the morning and in the it contains a huge amount of salt. Noon chai, we call it noon chai in Kashmir. This family, yes. You come, anyone comes in my home, first I will serve that noon chai. It is famous here, sir. In the morning, 2 cups, in the evening, 2 cups. That contains a lot of salt. If we say, for example, we have a CKD patient, or we have any patient who has a cardiac arrest, and if we will say him that you have to stop this salt tea, he will do everything, but he will not tackle down this thing because it is in the genes of Kashmir from the beginning. We use this salt tea here and there.
And I would like to add, Dr. Javed would agree, it's not only the noon chai that the Kashmiris have in the morning, it's about the kandar swacha also. I mean, it also contains soda, sir. So yes, Kashmiri breakfast is loaded with soda. It's loaded with soda and sodium, sir.
That also contains soda.
The trick is we have to change habits, but if you go in a straightforward, in a confrontational manner, the patient will step back. Even if the patient doesn't step back, his spouse will step back, or the mother-in-law. They will say this doctor is not good. So you have to take a tangential way. Dr. Ritika,
Yes,
your comments. We were talking about different spices. So how would we want to handle this? You can take tea, but this is the way. So in general, in the OPD, when you are counseling, especially in endocrinology or in chronic medicine care, so you say yes, you end with a yes, but in between you portray whatever you want to. So Dr. Ritika, could you help us complete now? Dr. Saqib and Dr. Javed, they are stuck with this patient who is taking salt tea 3 times a day. The patient is still willing to listen, but the wife is not willing to listen. So I'll give the first sentence and the last sentence. The first sentence is yes, salt tea is good. We have been taking it for 1,000 years. The end is yes, if you wish, you can take salt tea, but we have better opportunities for you, and this is what you will follow. Salt tea is meant for people who cannot afford other things. You can afford other things. God is kind to us. So in the middle, what will we say, ma'am? Different alternatives for the salt tea.
Like sir has, are we talking about the patients of heart failure, or are we talking about
Or
patients
CKD,
in
yes,
general? Even CKD
hypertension
and
also.
all, we have to
Yeah, we are labeling as resistant or refractory hypertension without even focusing on the diet. So just some suggestions, whatever comes to your mind.
I think for Punjab people, I can just tell them you can take some buttermilk in between if they're very fond of taking tea at that time. Or even what I advise to my patients who are taking like 4 to 5 cups of tea every day, I just tell them start with the cutting chai. If you are taking a cup full, start with 100 ml. You can take frequent jitna le rahe ho. Then after, if the patient has adjusted to that volume, like now he's adjusted to cutting tea of like 80 ml per 80 ml 4 times a day, then in the next visit I'll suggest them now cut down on the frequency, and in between we can juggle between things like we can offer them soup with low salt, like a mixed vegetable soup or something. Patient can take that. Then buttermilk is a good option in the patients in Punjab basically. If you don't have, if you have to restrict fluid that much, I offer them you can take curd in between, small snack like makhana or chane, just to fill in that gap for the patient. This is what I advise to the patients.
So, Dr. Javed, some suggestions, extra suggestions. First of all, begin with yes. Yes, tea is good. So we are on the same page. Patient is agreeing with you. Now you say, but yes, see, salt, when was it started? It was started at a time when no other nutrients were available. We have enough salt in our food. Let me give you better alternatives. Not B grade alternatives, better alternatives. So the better alternative might be cinnamon, dalchini. It might be elaichi. It might be saunf. But you have to add some kind of an adjective or a qualifier. If Dr. Javed says only saunf or only dalchini, that is cinnamon, or fennel seeds, or only elaichi, cardamom, that value is not there. So let's add. आपने दालचीनी जरूर लेनी है, मगर cigar wali, which comes in the original pack, या श्रीलंका wali. And this all of us are able to understand. So you have to add a particular kind of a cinnamon, which is economical also. But you go to the shopkeeper, you ask for, the English word is quill, Quill, and usually here our shopkeepers will say Singapore quality, Sri Lanka quality, or cigar or cigarette quality, because it looks like that. If you want to say elaichi or cardamom, then double elaichi. दो elaichi डाल के डालें, पीस के डालें, and you practice with that. And then you say, you might like cinnamon, you might like elaichi, you might like both of them, but let's try. This salt is for, it's outdated, it's old-fashioned, madam. It is good, but now you have better things. So this is the way to get them on board. And something or the other will work. It can be peppermint, it can be cinnamon. And like I said, that plan B has to be there. So the plan B will be Ceylon cinnamon, or it will be Zafrani chai. And these are ways which will help in every aspect of it. Patients also realize that you do not have to be a good cook. You do not have to go to the kitchen yourself. But when you're able to speak about things like this, how to cook tasty food without salt, how to quench your thirst with less water, patients appreciate that. They understand and they feel that, yes, you are thinking of me as a human being. You understand my challenges. Dr. Saqib also shared so many insights with us. But our topic today was, where do the guidelines converge? And we've seen that there is so much of convergence. For me, it has been a very beautiful day, a very beautiful 45 minutes today. Different colors, not separate, but all coming together as one rainbow, as one spectrum. And our experts have been so great, Dr. Javed, Dr. Ritika, Dr. Saqib, all bringing their own color, their own expertise to the management of this rainbow. That is what we all do together. 4D is detailed discussion and dialogue in diabetes, in Indian diabetes, and it's doctors from across India who are gathered here. Let's take final comments from our experts. So, Dr. Ritika first. Madam, anything new that you learned today? Anything you would like to share with fellow physicians across India?
There was lots of new learning about what sir is saying in Kashmir and learning about the new Nuskha sir, which you actually have told on this national platform. I'll try to gather those as well and practice in my daily routine. And to all my fellow physicians, like we all said, it's a rainbow, like you quoted, it's rainbow of multiple colors. And diabetes, it's cardiorenal metabolic. So I won't say it converges. I'll say they all three start together when the patient has diabetes in middle age. So day one itself, the patient is not a diabetic. The patient is a cardiorenal-metabolic syndrome patient itself. That is what I will say. So we have to focus on all the aspects from day one itself, rather than waiting for the complications to start.
So don't think in terms of convergence or in terms of consecutive approach. It should be all together. It should be a simultaneous address.
Yes, sir.
Dr. Javed, endocrinology is known as the rainbow of medicine because we have so many different glands spread all over the body. So your comments, your final take before we conclude.
On this discussion which was about the PKM, sir, the most important thing which I learned today is that the person patient is on some one drug, patient is on some is some diet pattern. Change how to tackle that diet pattern, how to change that. So beautiful that those things that we can give you some more that I think which has a more benefit as compared to previous one. What the patient is using. For example, patient was taking salt. Then we add in that ilachi, cadmium, so many things. So that we do not directly ask the patient to stop this thing and this thing, will be annoyed by that. That was the beautiful thing here. With that, how we will tackle that in the patient who are in clinic, who are stubborn, diet, and that will improve that this outcome in that patient. That was very important learning. Thank you, sir, for that.
Thank you. For me, the beauty is being with Dr. Ritika, Dr. Javed, with you, and with Dr. Saqib. We have such dynamic doctors now, and everyone who is listening to us, everyone who contributes to 4D. When I'm with you, I feel young, I feel energized, and I feel very confident that our country is in safe hands. So everybody, thank you for being with us. Have a great day, and don't forget to stay tuned to the next edition of 4D as well. Thank you, everybody, and goodbye.
Goodbye, sir.